We'll now get to the idea of exploring value in healthcare and why we should make a big fuss about defining what is value in healthcare, especially from a patient centric standpoint. You see, a doctor is trained to defeat mortality, to overcome morbidity, to neutralize all the disease conditions that is afflicting their patients. And thanks to God for that, and thanks to the doctor for keeping us alive and keeping us well. But understandably, because of that goal, all the measurements that the doctors or the hospital, the clinical departments capture, are around metrics that matter to the doctor. Sentinel events, preventable mortality, readmissions, complication rates, sentinel events, medication errors, reporting errors. I'm not saying these are not important, but is it important to me as a patient? I don't know, not so sure. Because a patient is not about the disease condition. The patient is about living an independent, constraint-free life. And those factors that are important to the patient does not find adequate space or voice in the metrics that are captured today. I will share with you a large-scale study of metastatic breast cancer patients that was conducted in the Nordic region, which will clearly demonstrate this massive gap and contrast between what is important to patients, but what is actually captured and reported either by hospitals or registries or clinical departments. But before that, I want to share 3 quick stories which affected me deeply and I think are at the heart of this idea of value in healthcare. The first one, a very close friend of mine, someone I studied together in college, we did engineering together. We've been in touch occasionally, but many years later, when he got in touch with me, he was diagnosed with a terminal illness, glioblastoma. He was admitted in a hospital where I was CEO. I kept constant tab on his condition, visited him frequently, constantly communicated with the doctors, surgeons, oncologists on his condition. And every time I would go to meet him with trepidation about what was about to happen, he would always complain to me about his constant urge to pee, to use the washroom. But pee he could not. It baffled me. I found it weird. I tried to tell this to the doctors, and he would vehemently mention this to the doctors. The doctors would hear him, but they were so focused on extending his life. They did not pay attention to what they thought, I think, was a trivial complaint about passing urine. But it consumed him completely. But the doctors were focused on one thing, extending his life, trying to defeat what was inevitable, which they did for another 45 days. But in that entire period, he was preoccupied with this particular condition. We lost him in about a month and a half. And in retrospect, I wonder if the doctors had just focused on what was important to him, maybe he would have had better conversations with his 3 lovely, beautiful children, his wife, his near and dear ones, instead of being consumed by this condition which affected him so deeply. This thing and those images haunt me to this day. I could have done better, maybe. And then a similar situation visited me again with my dad. He suffered a hip fracture. He underwent hip surgery. The doctors came to the room and proclaimed that the surgery was a success and everything went very well, and they all sounded very pleased. But after discharge, my dad was confined to a wheelchair, and could walk with some difficulty using a walker. For an active man, that was a death blow. He was devastated psychologically, and it was just downhill after that. We lost him within a year and a half of that surgery. It dawned upon me that what is relevant to the patient is not even a conversation before we undertake significantly large or important procedures. Maybe it is, but I just think it's not done often enough. Another story with a happier ending was from this close friend of mine in Kerala, in Kochi. She called me, and her dad had suffered a stroke, and he was recommended an invasive brain surgery. He was 85. There's a risk of collapsing on the table, and the other option was to just palliate and, let him be pain-free, but, let him exit gracefully. And confused about what to do, and not arriving at any kind of conclusion with her family members, she called me and we discussed. And I suggested to her that the best person to answer this is her dad herself, and that she should go up to him and tell him the options, which she did. She came back to me and said, my dad was exceptionally calm. He heard all the choices and he responded saying, Mole, which is Malayalam for daughter, a language spoken in the southern state of Kerala in India, said, Mole, if I can watch cricket matches and have parampuri, a local delicacy, banana fritters, then I'll take my chances, he said. My friend took this demand to the surgeons who thought it was reasonable. They performed the surgery, and Ganeshatan, her daughter, my friend's father, recovered, responded well. He enjoyed many cricket matches, enjoyed his delicacies, lived life to the fullest, and passed of natural causes almost 6 years after that incident. And his demand was very simple: cricket and banana fritters. Now, that's not trivial. That is important. But that conversation of what is important to that patient is sometimes subservient to the single-minded focus of extending life and defeating what is inevitable, mortality. It dawned upon me that patients' priorities are not factored into the outcomes and into the measurements. And the idea of exploring value in healthcare is about including and not divorcing the patient's expectations, and somehow including that into the design and care plan. But there are some fundamental challenges, and that is that we've not yet developed statistically sound or scientific methodologies to adequately capture and measure what this value means or what a patient-related outcome is. And on top of this, our costing methodologies are primitive, as we discussed earlier. But having said this, it doesn't preclude us from having the conversation around what is important to the patient and documenting that and making that part of whatever the doctors are trying to do with the disease condition. Michael Porter, in his seminal article, What is Value in Healthcare, defines value as health outcomes achieved for every dollar spent. That's typical microeconomics, right? And this framework that Porter defined, which was also based on the idea of time-driven activity-based costing, was used by ICOM, a not-for-profit organization, ICHOM, to define outcomes as the results that people care the most about when seeking treatment, including functional improvement and the ability to live normal, productive, and independent lives. They've published, I think today, 12 or 15, I think it's about 12 global standards. And these are developed by clinicians, patients, registry leaders, sitting down together saying what is important for each of these conditions. I think you should Google ICOM and look at some of these standards and see if they're applicable in your institution. So, in healthcare, where teams are currently trained to focus on whether a treatment is effective, but to understand whether how that treatment impacts the patient's quality of life, physicians need to ask personal questions to the patient of what is important to them. And that is when we can actually develop a meaningful value equation in healthcare. Let me now share the study that was done in the Nordic region that contrasts the difference between what is measured by doctors in registries and hospitals versus what was important to this large cohort of metastatic breast cancer patients. Up next.